To start with, this patient, I was involved in his treatment with my mentor in France 3 years ago. This is the 9-year-old premenarche. Her parent noticed unequal shoulders. She was asymptomatic and she was neurologically intact. So this is her X-ray, shows a segmented vertebrae at the level of L1. So she's 9 years old. The question came to our mind when we can do the surgery, and does the early surgery will affect the growth of the patient, and if younger patients can support surgery at younger age, or should we apply the concept of the idiopathic scoliosis waiting until the mature age, then we can do fusion surgery. Also, there is another alternative for idiopathic nowadays, which is non-fusion techniques that next speaker, Dr. Petrovic, will talk about. We know that the congenital scoliosis is part of the early onset scoliosis. With other causes, this is scoliosis that develop in the developmental period for the development of the spine, and can be the incidence of congenital scoliosis 1 to 1,000, and it's a little bit high in the girl compared to the 2 to 3 to boys. The exposure to toxins and drugs can play a role of the incidence. There is some genetic factors for congenital scoliosis. So to classify congenital scoliosis, we have failure of the formation or failure of the segmentations. Failure of the formation will give us the segmented hemivertebrae with the disc above and below. And for some time, or it can also give wedge vertebrae. That means half of the pedicle would form. For the failure of formations, as we said, also can wedge vertebrae. There is a lot of types. Regarding the failure of segmentation, it can give either block vertebrae or bars, either unilateral or bilateral, and usually associated with rib fusion. We can also see mixed deformity, which combine both failure of segmentation and failure of the separation formation. Also, we have what's called hemimetameric shifts, when there is two hemivertebrae on contralateral sides counterbalance each other, which 15% usually in the thoracic spine. The natural history of congenital scoliosis, depending on the type of the anomaly, the locations, and the curve, usually progress more when in the early years of life and during the adolescent period. And they, in this paper, as you see, the simple progress less compared to the complex degree that reach could be 10 degrees. Another factor that indicates higher progression when the hemivertebrae located in the thoracolumbar region, or when there is associated with fused rib. Congenital scoliosis sometimes associated with other organ anomalies, so another system should be evaluated, and another imaging should be done for this type of patients. For the natural history of the congenital scoliosis, examinations, as we said, should be involved all the systems, and not only focusing on the spine, cardiac, renal, pulmonary, that could be affected also in these type of patients. Regarding the imaging, the X-ray to start with, AP and lateral, because usually the scoliosis associated with kyphosis, so to be ruled out in these patients. CT scan is important, not only the classic, even with 3D, that will help in the planning of the surgery, also should be obtained for these type of patients. MRI is mandatory. It's not like the idiopathic scoliosis that not necessarily indicated in every patient, but for the congenital scoliosis, we can say the MRI it's a must to be done with other imaging like renal ultrasound to rule associated anomalies. There is a rule for the non-operative treatment by observation, bracing for small curves can be applied. And the operative treatment, the question comes, what is the, for two things. Initially, the prevention of the deformity, because the prevention is easier than the treatment, and to correct the deformity, either acute or gradually. So we have many options, either inside to fusions, where there is a small curve, and usually it's a good option for the unibar and for younger patients that can stabilize the spine and give a good result. For hemiepiphysiodesis, that can work, but gradually the spine will grow for the contralateral. When we fix this is the orthopedic concept, when you fix the convex side, the spine will grow in the other direction, so gradually the curve will correct it with time. These need to be single hemivertebrae and should be in small curve to be work this technique. Sure, for the younger patient with involved secondary curve, the only option to do the posterior fusion with or without what type of osteotomy from the BSO to the complete VCR. Hemivertebral excisions is an option, especially for younger patients, that will able to make the goal to the disc above and disc below parallel, and can be a work in short fusion. As we said, the osteotomy and VCR is for the longer that involve the secondary curves, and it's technically demanding with high risk of neurological and bleeding. The option of fusionless surgery, it's either by growing rods or fibers, is also used for these type of patients with destruction that need to be done from time to time just to correct the spine. Regarding the literature, this is paper published recently in Eurospine Journal that 1,200 patients were treated in single centers, which they concluded that they concluded that they tend toward earlier treatments for these type of patients, and benefit of using shorter fusion with rapid recovery. And this is another recent paper talking about the hemivertebral resection in small children, literature review that published recently. These included many papers for the hemivertebral resections, and actually they concluded that even not only the treatment prophylactic surgery for the hemivertebral resections. It's an option that will enable less risk for the patient and have no affection of the growth of the patient or neurological or vascular problem for this type of patients. And they treated even younger patients until to the age of the 3 months old in this series, and there is no consensus about the age of the treatment, but they treated until to the 3 months, and 1 year can be treated for the hemivertebral resections. I will not go to the detail for this table, but to show you what is the recommended ages for these papers, and most of them less than 6 years old. Regarding the complication, although these patients treated early, and you see there is no actually in these lectures increased risk of neurologically or higher complication. All the reported complications regarding the either pseudoarthrosis or CSF leak or superficial infections, which is not very serious complications. This paper from Brussels, they reported where they treated by unilateral fixations with hemivertebral resection of 3-month-old, and proved this with time, this works, and without any complications. This is another paper that even these younger children can support simultaneous anterior and posterior approach with unilateral fixation, and they have good results for this type of approach. This French study, they see the patient after their puberty and evaluated 250 patients, and they concluded that early treatment would enable better results in terms of curvature angle and less extensive fusion. So there is some consensus by Colin Nadi in his paper, Early Onset Scoliosis, around the age of the 2 can be offered this type of surgery because we have suitable instruments and they have bony that can hold these screws. They shown also there is no earlier fusion, short fusion. It will not affect the growth of the vertebral body, so the fear of affecting the growth of the child will not be changed with this single small fusions. And it's safe in many papers, and it will not necessarily increase a neurological risk or another either anesthetic or that associated with this type of even the resection of the vertebrae. In this Growing Spine book, they mentioned that the progression may be fast or slow, and it accelerates actually in the peak, at the peak of the puberty. So if we diagnose these patients before the puberty, we can offer them this type of the procedures. So hemivertebral resection is the treatment choice and is superior to in situ fusion and other type of surgery. And in this paper, they treated about 50 patients, and they concluded that maximum efficacy is obtained if the surgery performed at the age of 1 to 4 years old. Delayed treatment for this type of patient necessitate longer fusion that will include also the secondary curves, and the option of shorter fusion, it will not be available for this type of patients.
Dr. Sultan, time please.
So the concept, just to say, For this type of patient, concept of the prophylactic treatment, it's preventive and better than to treat the curvature. Sure, we say yesterday this type of cases that presented by Prof. Kibish and Dr. Sami Isa and Dr. Anwar, where they are experienced and skilled with not every surgeon can do like this surgery, but if we diagnose them earlier, we can do this type of procedures. So for our patient, this patient has underwent unilateral approach with minimal invasive complete hemivertebrectomy, and the patient can, as we see here, this 3 years post-op, she has well-controlled spine and with well-shoulder balance. And this another patient we operated 1 month ago with this hemivertebrae with bar and fused ribs with PCR with separation of the fused rib, and the patient at her 9 years old, the operation went well and the patient discharged home without any increase of risk of neurological or another risk, operative risk. To conclude, for congenital scoliosis, early diagnosis and referral is very important. Early treatment will not affect the growth of the patient, and no increase in neurological or other risk operating in younger child. The concept of prevention much easier than the treatment of the curve. Shorter fixation, probably safe in younger child from longer fusion.